Okay, well, welcome back, everybody. How are you? I'll give my talk on what do we perfuse is the title of it, but it's really about stroke. And as I said earlier, Bob Groom really deserves a lot of credit for bringing this to light some years ago, certainly more than 10 years ago, and maybe even more than that. And it wasn't until I really met Dr. Garami that I recognized how much Bob had actually contributed to the concept of monitoring the brain, which is really a critical organ for us to be perfusing. I mean, as a perfusionist, what are we perfusing? Well, certainly the body as a whole, and certainly the limbs, and certainly the heart, and the kidneys, we use cardioplegia, the liver, and the gut, and all of those things. But at the end of the day, you gotta protect the brain. And we do a terrible job, I think, really, at focusing on this. We assume a lot. I think this picture for me says a lot. There's 100 billion stars in the Milky Way and 100 billion neurons in the human brain with over 100 trillion synapses. That's staggering numbers, really. And how do we measure the adequacy of perfusion? Well, we assume a whole lot. We do some fancy calculations. We monitor the SpO2. We do labs and look at the acid-base balance. We might even calculate the DO2, and we even use cerebral oximetry. But cerebral oximetry is kind of a tricky thing. I think we've been lulled into a sense of security with this technology. The concepts are easy, but making them work in a usable device is really very, very hard. The big problem with these devices is figuring out the saturation information coming from the skin, the subcutaneous tissue, the muscle, the bone, and the brain, and venous versus arterial blood. And being able to differentiate from all of that for any technology is really quite complex. And I would argue, and I'm going to show you a slide moving forward, I would argue probably not very reliable. Each of these devices of cerebral oximetry, and we know there's several on the market, uses a different approach for delivering light and analyzing the light being reflected back. Each device uses a different approach to compensate for adsorption by the different tissues. The analysis algorithm for every device is different from every other. No two commercial oximeters measure the same thing. The specific algorithm used is secret, and the companies keep changing their algorithms and technology. So a study in 2005 may not actually be applicable in 2013. The algorithm in 2013, more than likely not applicable today. No device is capable to provide a pure brain O2 saturation, no matter what the promotional literature may say. The signal from the devices is contaminated by a tremendous amount of extracerebral blood. And this is the slide that I think says it all. The cerebral oximetry readings there on the left is of a live patient. Now, if we were to kill the patient, well, we are still going to actually get, or could get, and frequently get, a brain O2 saturation with the patient deceased. But it gets even better than that. If the patient is deceased, and hopefully we would do this after they were deceased, and we simply removed their brain, we will still get a reading. And yes, a lot of people say an awful lot with very small or lacking any brain at all. Well, in stroke, there is no good stroke or small stroke or anything else. A stroke is a stroke, and it's bad. Perioperative stroke rates in cardiac surgery range from 1.7 to 2.9, but encephalopathy rates, which we're going to talk a little bit more about, are 7.7 to 13.8%, with these are frequently harder to diagnose. So you get the patient who comes in, they have a stroke, they have a hemiparesis, they're unable to speak, their face is drooped. It's obvious they had a stroke. But there's a lot of strokes that are simply not seen because they're not gross. But the family says, Uncle Joe is just simply not the same person. They're more forgetful. Their personality has changed. Their attitudes have changed. And these are these subtle changes that you see. And frequently these patients can become very combative in the ICU, delaying extubation and also delaying transfer out of the ICU, increasing costs at the end of the day. So let me take a quick break here and beat on myself and some of my perfusion colleagues. Do we, as a routine, have any idea what happened to the case unless we get called and it's a callback for bleeding or whatever it might be, or we're putting the patient on ECMO in the ICU? Generally speaking, do we go and check on these patients in the ICU? Do we ever see the patient post-operatively, or pre-operatively, and assess these patients before they actually roll into the operating room, which is really more than likely the first time we ever have any exposure to the patient? And do we see the patient post-op at any time, in the ICU, on the floor, at discharge, or are involved in any way beyond the procedure that we did? So how do we know we did a really good job on this patient, and they're the same patient they were before we got them? Well, the answer is no, or infrequently. I'm not going to say no entirely, because I do think that there are some who are more heavily involved. Of course, there's considerations in terms of how much time we have, how many cases they're doing, staffing levels, and so forth. I do understand all of that. But irrespective of that, I think that at least some level of following this patient post-operatively may be something that we as a profession may want to consider to be more a part of our responsibilities. I think it would teach us a lot. Strokes are deadly. There's a threefold increase in mortality at the end of 10 years. They're debilitating. For many, especially the elderly, it's worse than dying. They would rather die during the operation than wake up having had a stroke. They can't maintain their independence. They can't enjoy normal activities. Their quality of life is severely compromised. They have decreased cognition and mental ability. And it is incredibly financially devastating for the patient, for the hospital, and for a society as well. So there was a whole point of time in our history where the pump was bashed. It was all about the pump. The Wall Street Journal circa 1990 blamed the pump for cognitive dysfunction. It was considered pump head, if you all remember that, those of us old enough to remember that. Dr. Stump, of course, did a lot of work on SCADs. Of course, we were transitioning from bubble oxygenators to membrane oxygenators, and of course, that made a big difference as well. Off-pump cabbage craze came into vogue, predominantly over this concept of pump head. And there's another article here of off-pump versus on-pump coronary. The coronary study, I love the way they do that. The coronary study is coronary, off-pump, on-pump, and something else. It's the acronyms really are pretty good. But this was 4,700 plus patients from 79 sites in 19 countries. And what they found, if you take a look at this slide here, is that really on the primary endpoints, that what was the real problem, and I can't get this to work, but if you look at stroke was a little bit worse on pump. Oh, thank you very much, Zsolt. On pump than off pump. But death rates were the same. Non-fatal MI was a little bit worse. New renal failure was actually worse in the off pump group. But when you look at the Syntax trial, for example, they talk about, when the cardiologist goes and talks to the patient, they say, look, your stroke probability in this operation is going to be this. If we do this stent, it's going to be less. Or the surgeon says, if I do it off pump, I'm going to have a slightly lower stroke rate than if I do it on pump. So, you know, those are the kinds of things that I think really matter. And how much of this stroke is really related to the pump? How much of it's related to flow if you are on bypass? How much of it really is embolic events? We know the cross clamp creates a problem. The Embelex catheter used to be in existence. Of course, it's been removed from the market. Sadly, it was a great device, but that was a political problem with Edwards and the FDA, and I think that really needs to come back. But the study, the coronary study, concluded that at 30 days there was no difference in the primary outcome between off-pump CABG and on-pump CABG. Off-pump CABG was associated with less transfusions and reoperation for bleeding, less acute kidney injury, less respiratory infections and failure, and more early revascularization. So that's very important. So if you had an off-pump CABG versus an on-pump CABG, then your grafts were more likely to close than if you had the operation with a still, quiet heart. So it really isn't the pump. Is this too early for this morning? I don't know if it is or not, but that's basically how I feel about this whole argument of off pump and on pump. I think you do a much better operation on pump than you do off pump. At least that's how I would want my coronaries done, and hopefully I won't need coronary surgery. At least I'm hoping that. But I would rather have it on pump. But I think that if I had it, I would like it to be with TCD. So something that has really brought stroke to the forefront and what we're thinking about it in terms of the cardiac surgery world, whether it be coronaries or valves or anything else, is actually TAVR. So it has opened our eyes, and it occurs a stroke occurs in TAVR nearly 100% of the time, and I'll explain that. Majority are embolic, and all strokes, whether they be gross frank strokes or whether they be these subtle changes that occur, are consequential. And it has launched a new industry in cerebral embolic protection devices. So let's talk about that 100% stroke rate. Here's a diffusion-weighted MRI of a brain, and you see the white lesions in there. The arrows are pointing at it, and also on the right. And these are embolic events. These are new lesions on diffusion-weighted MRI. So the new stroke classification says that you have to have, for a new device, a new TAVR valve coming out, for example, you have to have a pre-op and a post-procedure diffusion-weighted MRI, and you check to see if there are any new lesions. If there are, then it is considered a class 2 stroke. So class 1 stroke, what we're all used to seeing, you've got a major problem or worse, and in a class 2 stroke. So with TAVR procedures, and I'll say it again, 100% of those patients are having strokes. Now, with that said, we don't know what's happening on pump. We don't know what's happening with just heart surgery in general, manipulating the aorta, clamping the aorta. But I would suppose if we did diffusion-weighted MRI on patients who have heart surgery, they too would have new lesions, and it's probably pretty close to 100% of the time, I would think.
Well, this is a great proposed study. We definitely do not have DWI after CABS, and I think the previous publication was the 4,000 numbers were really impressive. I remember
the coronary study?
Yeah, because I remember publications, just 20 patients in the same group, and in those cases when we studied with TCD or DWI, we saw immediately a embolization difference, but at the 6-month outcome, there was no difference. So even if you're looking for these subclinical DWI lesions or cognitive changes, I think we still need to define and we need to better tune even our cognitive function changes. Mm-hmm. So these subclinical stroke, what the DWI picks up, it's maybe not subclinical at all, because they are accumulating. We do not have the clinical effect right now, but maybe 3 months down the road when the patient don't remember the name, those are the changes may result of these DWI lesions, not at that moment, but maybe down the road further.
Now these are embolic lesions.
Yes,
what I'm
but
seeing here.
these white dot means that those are dead
neurons.
Dead neurons with free fluid outside. Means that the cells, they release their contents. That content is never going to come back. Sometimes we talk about diffusion changes which are irreversible and reversible. Sure, reversible, but it means that they are gone. So I think it's very important that these white lesions are only positive up to 7 days. So if you had a procedure done and you do a DWI 10 days later, you're not going to see anything. So you really want to do the DWI MRI as closest to the procedure as possible. So you also have the DWI lesions related to that procedure. So you don't want to do it 5 days after the procedure because you don't know what happened the postoperative 5 days. Those postoperative 5 days blood pressure changes, anything can relate and result on those DWI lesions. So I think it's very important that within few hours after the procedure, we need to see these DWI lesions.
And that's difficult. That's difficult to do when you are, in the ICU. Maybe they do an early extubation. Maybe they're still on the ventilator. It's going to be very difficult to do this for CABG patients. But I do think that we don't. Really, at the end of the day, we just simply don't know, and that's, I think, one of the biggest problems that we have. So I want to show you this video and kind of explain a little something to you, how marketing works. You see the catheter going up. This is a TAVR procedure, and you see the balloon right there. And I want you to take note. Look at how beautiful, almost right in the central lumen, that catheter goes up. Now here comes the device, and it goes up the vessel, and they just going to deploy it now. Here it comes. Watch it come up and go around the arch. I want you to watch this. This is why 100% of TAVR patients have strokes. So this is what the marketing shows you. This is what the public sees. And there it is right there. Okay, now we're deployed the device. And there we go. We're rapid pacing. Now the valve has been deployed. And the heart's beating again normally. And they extract the device catheter, there you go, and the wire comes out. Did you see how pretty that was? I'm not going to show it again, but if you want to go back and reverse it and see it, you can. But this is a reality of what you see. In picture A, you see that same catheter coming around. So when those wires go up, they tend to ride up high, and that catheter is a pretty good sized catheter. What's that? It's a 20 French, right? 20 French or 22? It's
I think
really
we started
big.
24,
maybe
but right now it's 18 now.
18 French. It's still pretty big.
Yeah.
And that has to make that curve around the arch, and it scrapes the wall. And as it scrapes the wall, it knocks off calcium, atheroma, and anything else that might be there. And then it goes in, and then you deploy it or inflate the balloon or whatever the case may be that you're doing. And of course, there's calcium on the valve that's going to get broken off and go flying upstream. And then there you see the device with some residual. And this is what the cerebral embolic protection devices look like. So it gets deployed in the innominate and comes down, and then you block the innominate and you block the left carotid. The left subclavian, we're not worried about their fingers. And this is something I think you're going to see more of in cerebral embolic protection devices. It'll be interesting to see if it becomes a standard of care for routine procedures.
Well, I think we still need to study this because interesting trials and FDA approved definitely, for example, this CRED device. It's important that these treatment and control arms, they have similar lesions. So until you really don't see the huge improvement of that, you are protecting the brain, you have less DWI lesions, you have less embolization material picked up by the TCD, we shouldn't be happy. So I think we started to care about protection, but I think these devices are still not the perfect devices. Definitely while you placing these protections, you have unprotected period, exactly. So you do have unprotected times, and when you're retrieving it, you're closing that filter up, you're definitely going to squeeze out a few of those embolic material right there. So I think these deployment versus collecting those debris needs to be probably improved a little bit.
Yeah, that's really interesting. I mean, it's really amazing at how something that looks so simple when you look at marketing material is so difficult to actually do in real life.
I think there's, if you really do the science with 100% honesty, you know that these filters are not going to capture everything. So if you look at the filter porous size, which is 100 micron, what is your filter? I'm sorry.
That's right. It's 40.
40.
That's right.
Think about the 100 micron versus a 40 filter on your pumps.
Yeah.
So definitely we learned that majority, I think we did a study in the carotids, 80% of the material is passing these filters.
Wow.
80. So
Wow.
definitely we need to learn more about, my problem is that if you go down to 40, you may be definitely clogging up because you will collect so much material that you're not going to provide a flow. So we need to find a better way how to filter the materials. 100 is definitely not the perfect size. 40 is probably hard to do.
Yeah, just because of surface area.
Yes, but I think these debris, when you're looking at even those pictures, this is a macro embolus. This is a big piece of chunk on that picture.
Yes.
You're not going to see these with your eyes. So I think the same thing how we see DWI is a subclinical stroke. These are probably need to look as a really tiny pieces. So TCD will pick up something bigger than the red blood cells. Red blood cells 7 micron. So think about 7 micron to 100 micron. So definitely there's a huge room for the debris to really size them up, and I think the sizes does matter. I'm so sorry to start start an early morning conversation, but after the elephant joke, I think I'm ready to go on pump.
Thank you very much. So, these are really incredible, interesting points. But, one of the things, and I'll get to my slides here, but one of the things that I find fascinating about all of this, it's not only about embolic events, it's flow. And we just always seem to talk about emboli, but we don't really talk about flow. We don't talk about capillary opening pressure. We don't talk about the resistance to flow caused by venous congestion, for example, as I was mentioning earlier, and how that affects the flow patterns through the brain. So we keep focusing on this embolic phenomenon, but we don't really think about or talk about it's about flow. It's about flow, it's about your CO2 level, it's about your oxygen carrying capacity. All of those functions are relevant to this conversation.
Yes, and I cannot wait to show my slides, which is going to list you the hypo and hyperperfusion. So I think we really need to study the flow as how the hyperperfusion affects the brain, but also sometimes the luxury perfusion, the too much flow, it's not good. So I think we need to learn a lot.
Luxurious perfusion.
Yes, sir. So I think the cooling part and how fast you warm up, those are the time periods. I think the brain is really sensitive, and we shouldn't rely on, well, when I'm cold, easier to control the bleed versus what does it really do to the brain. So I think we learned a lot from all those ascending surgeries when you have a circulatory arrest cases. We do learn a lot from those high complications to how to make it safer and how to control and how to even provide flow for those circulatory arrest cases.
Very good. So not all strokes are caused, by the pump. Cross-clamping the aorta, for example, is a big component. Removing the clamp is in fact touching the aorta at all can create these problems. It could be anatomical. It can be a lot of different things. But the pump is certainly not free of stroke risk. Hyperperfusion, gas or particulate embolic events, hypocarbia or gross hypocarbia, cannula position, drainage, and of course pump failure. All of these things can result in a big problem for us in terms of hypoperfusion of the brain. We know that clamping and unclamping the aorta is a problem. Heart position affects flow, and of course we're trying to help the surgeon get through the operation. And another thing too, something that I just thought of is there are a lot of some perfusionists, when the surgeon says down on the flow to put the aortic cross clamp on or to take it off, will take a clamp and they'll clamp their arterial line. They'll just put a clamp on it and close it off, and of course the flow goes down, the pressure goes down, and they apply the clamp or remove it. Some perfusionists, and I think probably most, turn the rheostat control down, turn the RPMs down. But sometimes you do it faster and go back up faster. Sometimes you do it a little slower and a little back up. We have no clue how that variation, acute sudden change, affects the brain. We have no idea if we go down too fast, does it create a problem? Come up too fast, does it create a problem? I think it's going to be interesting. If we were to start using this on a routine basis, I'm pretty confident that how we practice would change significantly. We think we're doing a great job. I think I'm the best perfusionist ever walked the earth. I don't want to know the data because it's going to reveal how wrong I really am.
I think you're still the best perfusionist, and I think because you're really sensitive for the new knowledge and you're open for the TCD and all this information. And going back to your slides, I think it's very important to not to blame the perfusionist, not to blame the surgeon and also the anesthesia who's in your team, but kind of work together. So I think very important your cannulation site. Surgeons, they learn, well, not just looking at the aorta, but really do an ultrasound on that aorta and look at the other side, make sure there's no plaque there, would be safer cannulation, that you're not dislodging a plaque in that moment when you're just cannulating. Mm-hmm. So I think those are very important, and I think our anesthesia is always asking our TCD flow information, because when they see any pressure issues, it's so much easier to see how is it affected in brain. And it's stunning how the auto-regulation still works. So pressure change of between 20, it just reacts and the brain compensates with only 10% change. So I think those are the important information, how as a team we need to really communicate, and as well as a surgeon, perfusionist, but also the anesthesia, perfusionist, communication needs to be really strong.
Very good. So do we know whether our flow is adequate? And I think we assume a lot. Cerebral oximetry certainly is something that people use, but I don't have confidence in it. Do we know whether VAD or kinetic assist, vacuum-assisted drainage or kinetic assist has an effect? Does going on with the dry venous line really create the problems that some people say it does, or doesn't it? Is a closed system like a bag better or worse than an open system? When we go down on the flow, I talked a little bit about that already. How do we do that, and what is the best way to do that? Does pulsing, some surgeons now are wanting us to pulse on bypass, and I mean, you got a cannula that's 20 French. You're really not going to be generating much of a pulse pressure or much of an upstroke, and does it cause more harm than good in terms of cerebral protection for what we're benefiting by trying to perfuse the kidneys better? And how are we managing our temperatures in terms of cooling and gradients and warming and so forth? The brain is very sensitive to hypoxia. We all know that. It's very good at auto-regulating. The cerebral perfusion pressure and CO2 are critical. Dr. Garami is going to give us more examples about that. But it consumes 15% of the cardiac output compared to about 5% for the heart. So the brain is a huge consumer of oxygen. It needs a lot of blood flow uninterrupted to continue to function properly for the patient after their procedure is finished. And has this very conveniently positioned, the brain has this very conveniently positioned vascular system. So I'm going to go through this very quickly. We'll see this more with Dr. Garami. The carotid's coming up, the middle cerebral artery. You've got this temporal bone window, which is very good. Some women, I know you said, have a problem with it, but it's very easy for us to be able to put a probe on there and aim it and capture that MCA. In this article, detection of embolic events, we have I'm so sorry there. I'm not even sure why I have that in there, so I'm going to skip that slide. But how can we be a part of the solution? Well, look, I think we need to learn more about TCD. I really want to, in my group, in my practice, use TCD at some facility on a routine basis just to learn what's actually happening. It's, for us, a newer technology. The TCD devices of today are not the TCD devices of the past, and I think you'll highlight that a little bit. They're little laptops, very easy to use. It's also the head frame you talked about, very easy for us to apply. Now, there's complications. We'll talk about that later about getting anesthesia buy-in with it. I know at your facility you have it, but that's not a private practice facility, and it's problematic for us.
Well, the other thing is I think TCD as a technology can monitor your line. So right now we're talking about monitoring the patient head, but I think the TCD probe itself can be applied and can tell you, hey, you're sending embolization from your equipment. So I'm so sorry, I'm not a perfusionist, but I hope that behind your filter there's a flow meter or sensing what is the filter function is. So definitely that would be my idea of to really see what your filter functions, how does it work, and do you really filters everything out, or you can really blame on your machine that you're sending debris back to the patient.
Yeah, they do have devices for that. What's the name of that device that we were trying to, I forgot the name of it now. What was the name of that thing? Do you remember?
Yes, I remember, but
I'm not going
to say it.
Oh, good Lord, have mercy. Well, we have that emboli detection system for the pump that a couple of researchers...
EDAC.
Oh, yeah, EDAC, the EDAC. But they're not something that anybody uses, and there's a German company. In fact, EDAC's off the market. There's a couple of them still around. But you're absolutely right. We don't monitor the pump for embolic material coming from the pump. So is the emboli you're seeing with the TCD being generated from me or from the aorta or the carotid or wherever else it might be? We simply don't know. But it has billing codes, so there is revenue generation from it, and I think from what I understand, nobody's going to get rich off of it, but it certainly helps pay the bills in terms of the utilization of the device, the cost of the device, and the time that it takes to actually utilize the device, I would think.
And definitely cheaper than pay for the stroke. So I think when you have those $1 billion, when you're mentioning how much is a stroke treatment in the U.S., I think this is where not just making us rich now, it's more about keeping those costs related to the stroke down.
Absolutely, that's very true. But trying to convince an administrator of that, they just look at the cost. They don't think about that. It's very hard to convince them about these protective devices, and if this happens, this is what it will cost. It's very hard to convince them of that sometimes. It is very highly specific for both flow and embolic events. I think it can definitely help change a practice, can be easily learned by perfusion, can be a perfusion tool, which I think would be something that would be fantastic for us as a profession. And I think we basically just all need to get more involved to know what is happening with our patients. So this, I think, says it all. There are no knowns. These are things we know that we know. There are known unknowns. That is to say, there are things that we know we don't know, but there are also unknown unknowns. And these are things we don't know we don't know. Don Rumsfeld. That is prophetic. And in honor of Dr. Garami being our very first speaker, thank you all very much. I think we're going to get a word from our sponsors, and because we've got to keep the lights on, and then we're going to come back with Dr. Garami's talk. Thank you all very much.